Hello, and welcome to the Surgical Assistant Podcast, a podcast crafted by surgical assistants for surgical assistants, where professionalism meets passion. Hello, everybody, and welcome back to the Surgical Assistant Podcast. I'm John, and with me is Kelly. Hey, Kelly.
Hello, everyone.
How are you doing? And we are lucky enough. Oh, I'm glad to hear you're doing well. Thanks. Sorry. Today, we're lucky enough to have David Bartczak back, who's the owner of Mederi Surgical Billing Company, which is the largest surgical billing company in the United States. David's been doing billing for 17 years. He's worked in the operating room for over 24 years, and it was in the military before that. So he's got a ton of experience. And I am just tickled that David wanted to come back and continue to talk about that, because I think a lot of first assistants are interested in that, about working independent or billing or contracting with a hospital. But there is so much wrong and misinformation out there that I'm so grateful that he decided to come back and do some more podcasts with us. And I could just say from my personal experience, I met David at a conference years ago where he was talking about surgical billing, and I had so many questions for him. And one thing I really enjoy about David is that he's always willing to talk to you about it. He gives up his time freely. He just didn't hustle me off the phone by saying, yeah, we can do that. Just contact my company. I must have spent probably just 2 hours on the phone with him talking about this. And mostly of it was a lot of humbling information that I thought was going to happen that wasn't really true, but he's got a real world experience to dispel a lot of these myths and misinformation. So David, I'd like to welcome you. Thank you so much for coming back.
Yeah, thanks for having me.
Yeah, David, you're going to have your own spinoff podcast called Keeping It Real with David Bartczak.
Yeah.
FA billing.
Uncomfortable.
We've talked about the realities and being transparent, and how you bring such a diverse aspect to the field and to this specific topic. So I know it's something that our listeners are going to glean a lot from today in this conversation. And at the end of the episode, we're going to talk about, after we get finish kind of continuing our part 1 episode, we are going to talk about a new model, which in real time, we're recording this on October 19th. And you've just, within the recent weeks, announced on Facebook that there's a new model for independent first assistants. And we're going to really dig in and get some good information about that at the end of this discussion. So we're looking forward to that and bringing it to our listeners. Exciting.
Sure. Exactly. I'm so excited. So grateful that you could come back and do that. But I guess we'll pick up where we left off, about talking about surgical first assistant billing as an independent. And if somebody wants to be independent, I'm grateful for the information you gave us last time about all of the caveats that go along with that, how many cases per month you really need to do to make it logistically feasible. Don't think you're going to do 5 cases a week and survive like maybe it was in the old days. But also there's a great amount of cases that you won't be able to bill for. But if somebody was starting out, or wanted to contract with a hospital, or even work privately for a physician, let's say, and either contract to that physician or get paid an hourly fee, what's a fair rate that a surgical assistant should ask, and how would they arrive at calculating that rate?
So what most people look at, and this goes to some of the things we've talked about in the past, it's always a time thing. So how much time are you taking? How much time are you saving for them? Is the environment and the location close to you, far from you? Most hospitals, kind of the minimum is about $250 a case. That seems to be the kind of the basic standard. And then you go, okay, well, because it used to be they would contract with you and go, okay, well, we're going to pay you, $40 an hour, and we're gonna let you have a 2-hour minimum, and then there's a $50 per day call or a stipend that to come in. So most surgical assistants are starting at the $250 mark. If you're doing a standard case for most people is about 1.5 hours to 2 hours. So $75 an hour, you can back into it that way, or you can say, okay, I want $200 to show up, and that's going to cover you your first 2 hours. And then, you can make the math really complicated. And some people want it broken down that much. If you're doing plastics, we all know that that's a cash price, or, most plastic surgeons are including all of that price in at the very beginning. So, if you're doing, big revisions, um, you know, hardware removal, as we know in orthopedics, the hardest case in orthopedics is removing somebody's hardware that you didn't put in.
Mhm.
So, those can go, oh, well, I'm going to do $50 per case. Well, great. It's $50, but you might be there for 4 hours. So now,
Right.
was that a smart option? Some people do a tiered number where they look at the type of cases and how many cases, and for this amount of time in the OR. Um, the short answer is somewhere between 250 and 350 is kind of the going rate. Most of the hospitals here that I know of in Texas that are contracting are the 250 to 350 rate. And then you can add in the expertise, the usually the time that the doctor, like, we never really did anything that was over an hour. Our total knees, total hips were just over an hour. Our rotator cuff, it's a hard case, but we were done in 35 minutes. So if you go, okay, well, I want to get this much per hour, you're going to be, undercutting yourself. So, per case, um, based on the type of cases is sometimes good. And then a hybrid of some sort. And most doctors, um, if you're experienced enough to help them save time, and they're not getting called for wound problems, or
Mhm.
you know, you're like, hey, I can do this, and then I can come, I can help you with the orders, or I can help you with rounds, depending on what the hospital and the location allows. All of that stuff, adds value to your per case thing. I would say that that's, in most states, that's going to be your starting point.
Okay.
Okay. So also knowing your surgeons that you work with and how long it takes them to do a total knee per se, or arthroscopic or open rotator cuff repair. So if they're
Mhm.
quick and they do many cases per day, like I've worked with surgeons that do a 30-minute ACL reconstruction and do 6 in a day, then you're probably better off doing a per case fee rather than a per hour fee. Am I
Yes.
understanding that correctly? And then I know you said it depends on specialties. So, and some specialties pay more than others. So for spine or something like that, obviously very rarely do you have a 30-minute case, and like unless it's like a one level micro disc. But if it's a 3 level anterior posterior fusion with pedicle screws and rods, then you're probably talking 3 hours or more. So
Yeah.
that might be better served as an hourly rate then, as opposed to a per case rate.
Yeah. Well, and depending on where you're going, if you're negotiating with the hospital, they used to want to put you on the clock and give you an hourly rate, because then it was easier for them to track when you
Mhm.
were there and in and out.
Okay.
And usually you also have to add, it's not just the case, it's in the room time and you're out of the
Uh,
room time. So when
yeah.
the patient gets in there, the clock starts. And when the patient leaves, the clock is finished. So,
Okay.
like, we had docs that you would go in and prep, and the doctor wouldn't be there for 45 minutes.
Mhm.
So,
Hmm.
you know, but the hospital is always going to look at it as the most advantageous to them. So
Mhm.
hospitals are generally going to want the hourly. Um, Whereas if the docs, they just want the math simple, they'll say, hey, how much for, these are the kind of cases I do, how much to do those. But the questions really need to be, how much time do those take? Or am I now on call and have to come in? You have to add the whole thing to it, not just, because if you have to wait and you got to be within 30 minutes of the hospital at all
Hmm.
times, then your coming in needs to have something else added to it.
That was my next question. Let's say you come in on nights and weekends. Is that an additional fee, or like for being on call, you just say, okay, well, I'll come in at 2 in the morning and help you with a gamma nail, but there's going to be a flat $150 fee on top of that, or
Mhm.
is that even
Yeah.
okay to ask for?
One of the things that we had when we were on call, every time they called us in, we got another $50. So if they call us 3 times in the same day, we leave the hospital and we come back, it was $50. And then it was
Mhm.
a minimum of 2 hours on the hourly pay. So, it made it worth being on call. They didn't pay a call pay, but they paid if you in. And you just
Oh.
knew that if they were doing it, you were on call, you were getting called in. So you have to ask all those questions, I think, to really understand what's the easiest thing. People look at it and go, oh, I'm going to get $350 per case. But you do one case over the whole weekend and you got to sit at home the whole time.
Right.
What's really the best use of your time?
Right. And along those lines too, David, I want to ask about or just mention about how important it would be to know your OR teams, know your facilities, because how many times, John, have you gone in on call with the hospital? You get called in for a case and you're at that hospital 4 to 5 hours, but the case only took 2 hours. I mean, you've got anesthesia delays, depending on your anesthesia provider, how slow they are getting the patient down. Does the patient have any pre-op complications that they have to address? Last minute cardiac clearance, all these things that come up at the last minute that you can't foresee. So you really, I would think, and you can correct me, you really have to hone your discerning skills of when do I need to arrive at the facility for the case?
Yeah.
That I'm not sitting there wasting my time, because by the time you add all that out, you're making minimum wage.
Yeah. Well, I mean, you ask yourself, are you calling me first or am I the last person? And you got to have
Okay.
some order in which you're getting called.
Okay. All right.
I need to know, don't call me until 30 minutes.
I gotcha. Until the patient literally going to be rolling to the room.
Yeah.
Almost,
once you have all the clearances and, you just, because we also know that, some of them, the team will get the patient on the table and start prepping and do all that stuff without you in the room. So you're just there for the doctor. So.
And I wouldn't necessarily want that. I mean, I personally, and I'm just speaking for myself here, but yeah, I'm talking about like arriving to the facility for a case and then, hours go by before you're rolling to the room, and that's.
They called you first and you're sitting there all night waiting.
Right.
Gotcha.
And the doctor's lounge is all shut down. You can't even have food.
Right.
Yeah, true. So this brings up another question that I want to ask, and I'm looking at it from basically somebody that knows nothing about surgical billing and how would somebody, let's say, that is maybe a staff person that wants to start something like this, whether it's a hybrid billing kind of thing or a stipend from the hospital or something, how would they go about it? Who do they speak to about that? What do they present to them? I mean, and then when you bill, who do you bill to? I mean, I know it sounds basic, but I mean, like, if I wanted to start at the hospital I'm at now, who do I even start to speak with at the hospital about getting a contract or being a, independent SA that gets either a stipend or some scheme of billing?
So every hospital after they start is going to have some kind of plan for this. So normally what I tell people to do is start with, if you can get in touch with the OR director, then you talk to the OR director and go, hey, do you guys contract with independent surgical assistants, or do you allow independent surgical assistants? That or the HR department could say, hey, are we able to get credentialed as an independent surgical assistant? If they're not able to get credentialed, then that they have to come with the doctors. They're going to, the OR or the credentialing, someone on the credentialing committee. But usually you call HR or you talk with the OR director to find out what is their plan in place for, either after hours care or just general independent surgical assisting. Sometimes you look at, and, we used to have this conversation a lot was, well, I don't know what doctors work there, or I don't know. So you can start with the doctor and go, hey, where do you work? And then you back into the rest of that. But, that's hard to do if, none of the places they go allow a surgical assistant. You're all excited about, working with this doctor you met, and he's really excited about you, but you're not allowed to work there because they have their own plan already. So it depends on which one you find first. If you have no doctors that you know of, then you can talk to the facility. If you have a doctor that you know of, then when you call HR, it's like, oh, I'm going to, Dr. Smith wants me to help him. He comes here on Mondays and Wednesdays. How do I go about getting credentialed? And that starts at the credentialing committee or the HR department at the hospital. If you're just trying to, just fishing that if anyone uses them at that hospital, or if anyone's looking for one, you can talk with OR directors. Sometimes though, the introduction is better than trying to cold call OR directors, because they probably won't call you back unless they really actually need somebody.
Mm-hmm.
Can you start at the medical credentialing committee or the med staff office?
Mm-hmm. Yeah,
Oh,
you can start there just to find out if they allow it. And most people, understand which states allow it. Um, you know, the southern, I would say most of the southern states allow something like that. Nothing really on the east or on the west coast allows it. And up to the Carolinas allows it. I don't know.
So there's a precedent. So there's generally a precedence for it regionally. So even
Yeah.
if, like at my facility where I work, even if they've never credentialed an individual first assistant, it's likely allowed here in Florida.
Yes.
I mean, yeah.
Yeah. Oh, yeah. It's absolutely allowed in Florida. They're everywhere.
I was going to throw a scenario at you. I know this is a real life scenario. Currently know a first assistant who I haven't known very long, was living in Kentucky / on the border of Cincinnati, Ohio. And during COVID, which was an advantageous time, depending on how you looked at it, was able to do exactly what you're talking about. He was able to, when everyone, staff was leaving the hospitals in droves, for whatever reason, and it was during the pandemic or coming up on the peak of the pandemic, was able to reach out to OR directors, cold call them, and say, I'm available. He had to form an LLC. He understood that he had to form an LLC, and he did for himself as an independent contractor, and was able to go in and contract. They needed help. They needed first assistants, and he was able to write his own contract and contract with a facility, a reputable, kind of big facility there in Cincinnati. I say kind of big, maybe it wasn't huge, but to hear him tell it, I mean, it was a lucrative opportunity for him, and he was busy and he was working, but he was able to do exactly what you're talking about. So did that seem feasible to you, that he formed an LLC and did it? He got his.
Well, the staffing thing, they were paying $5,000-$6,000 a week minimum for people to go in and do our staffing. So if willing to come in there independently, that saved the hospital thousands.
a ton.
And I think he came at it from that angle.
Yeah, I had a staffing company post-pandemic, and they were making $9,000 a week. So
it's yeah.
But
like he gives an example. Yeah, he gives an example of saying, he gave the number $250 flat fee to be on call, $250 flat fee to be on call, to take a call shift. And then obviously if he got called in, it was time and a half for whatever rate. So he acted as his own agent. I mean, obviously it sounded feasible to me. I thought, well, gosh, that would be great if we could do that now. I mean, I guess what I'm asking you is, was that unique to the COVID pandemic situation? Okay.
No, there's
really
the challenge that you have now is hospitals are just backfilling it with bodies.
Okay.
So back then they would take anybody. Now they're like, well, we have a scrub tech we can put in there. We don't really need a surgical assistant. Or they don't even know what a surgical assistant is.
Correct.
Because you're either a nurse, a PA, or a doctor. And then now, okay, well, you're none of those, so you must be a scrub tech. So they don't really, you have to teach them what it is that you do. And then you can then go, okay, for that, this is my value. And this is what I can offer. And, like I said, in most southern states, they get it. And
there's been a reason
do that exact thing.
Yeah. And I love that we can have this discussion. And I'm trying not to draw this out too long or go off into little rabbit trails, but to apply it to real life situations. In my mind, I'm seeing a lot of discussions and first assistants that are our age that are getting quote unquote burnt out, or they just feel exhausted from the work, from the general work. That's all I'm going to say. And I try to tell people, y'all, there are options. I mean, you can flex your schedule. You can do PRN work. You can go to work for a staffing company. And I have never worked independent, but when I hear you talk about some of these things, I'm coming up with, scenarios that are so feasible to do. For instance, I was working recently with a resident, John, who was his 5th year. He was
Mhm.
about to branch out. So now this resident has started his surgical practice in a hospital that is about hour and a half to 2 hours away, no more than 2 hours away from me. And he is going to this small, kind of a rural hospital. And asked him, I said, "Are there first assistants in that operating room?" And he said,
Mhm.
"Why are you interested in coming?" And
Mhm.
I told him, I said, "Well, if they don't have first assistants, I'm happy to come speak to administration and educate them on what a first assistant is and the value that they can bring to the operating room, because we're continuing to find out that people do not know how we're trained, what we're able to
Right.
do, and this." So now but hearing you talk, I'm like, "Wait a minute, I could contract myself with that hospital. I could do this." I mean, I could do that. If they
The,
don't
the,
have I don't know if they have first assistants on staff or not. He didn't seem to think they did.
it seems the biggest challenge that people have and the leap between the employee and the independent, you don't always make more money. You just
Mhm.
control your time.
Mhm.
Right. And
You know,
there's value in that
Well, it's a
depending on
good
how you look.
work-life
you
balance.
your time.
Mhm.
Yeah.
But what people tend to do when you could control your time is you work all the time because you're like, well,
Mhm.
another opportunity came out.
That's
Because
Mhm.
true.
make more money, the less time you say no.
Yeah,
That's true.
You know?
a
But
good point.
then you have to look at, I've always told everybody, don't do free cases. There's no
No.
reason somebody should be paying you for them, or don't go in,
Mhm.
because as long as you're willing to go in for free, they're going to keep having you
Oh,
come in free.
Oh, sure.
So,
absolutely.
and look, we're the only ones in the OR, and I think I mentioned this the last time. We're the only ones in the OR that go to work every day and have no idea whether we're going to get paid. Everyone else in that room already understands what they're getting paid.
Mhm.
So you can't go into it with, oh, I just got to work. I don't know. I think people have made a lifetime career out of living off the government. If you're going to make
Mhm.
$25 an hour sitting at home, why
Yeah,
would I go in for free to
right.
put all the risk? Because you have the exact same risk at the end of the day as the doctor does when they
Mhm.
get sued. Whether even if it probably isn't even your fault, but when they get sued or the hospital gets sued, you get sued also.
Mhm.
So you have the same risk. So you shouldn't be doing that for free. But it was all the rage before because people were making decent money
Mhm.
um, on the cases they did get paid for. So like, oh, I'm going to
Mhm.
do some free ones. Well, you don't get to write off that time. You don't get any value back on that. You get
Mm,
experience.
right.
But at some level, your time is just as valuable as everyone else's and needs to be reimbursed. So most hospitals understand now if you're coming in and you're covering call and you're covering things, that they're going to have to either provide a stipend or provide an hourly or provide something. The hospitals get paid for surgical assistance, whether one is used or not,
Right.
because that's just how their DRG is formulated. So there's money in the budget for it. They just don't. They won't. If they don't spend it, they get to keep it. So the doctors
Ah,
have for something, and the doctors have to say, "Hey, I need this person here. You guys need to pay them something."
Mhm.
So
mhm.
it's a full circle. Everything can start and end with the docs, but sometimes the docs go, "Hey, I want you, but I don't know anything else." So you have to educate yourself on, like you said, start a LLC, be a business, but then now you have to run a business and a medical practice, which
Mhm.
are run totally different because you have that I want to help everybody attitude in the medical side, but then you have my mortgage doesn't get paid with, hope and rainbows. I
Right.
have to have money.
Right.
Right.
You've got to do both sides of it. And I think that's the problem a lot of people have, that leap. And everybody wants it easy. And then it circles right back to the original question. You just tell somebody, whoever is willing to pay you, this is how much my time is worth for that.
Okay.
And the easier you make it for them, the more likely they're going to get a yes. But, that first one or even first few, you may be undervaluing yourself to get the experience and figure out what the cost actually is. And
Mhm.
then, going forward, you can look at it. there's not really the hospitals don't have as much shortage as they used to.
Mm-hmm.
Going in there and, kind of putting your own spin on it is not as easy as it was pre and post pandemic. But most of them understand that, they're not going to let you necessarily write the contract, but they'll tell you, hey, give us something. And then, our lawyers will write it up.
Yeah. Okay.
But it's feasible. It's not as easy because, most of the big hospitals have some kind of group. So the advantage would be the small surgery centers or the smaller hospitals outside of the normal area. But
Mm-hmm.
then you also, if you're independent, you have to look at it as, okay, well, what am I going to bill the insurance, or are they just going to pay me by the hour? And that's what I'm going to make.
Okay.
I do have a question that dovetails with what Kelly was saying and what we were talking about. I understand. I mean, immediately post the incident that we won't talk about, I think a lot more hospitals were more readily willing to do that because they were so short-staffed. They were
Mm-hmm.
getting government subsidies. Their doctors needed help. But nowadays, I mean, at least from my perspective, I'm seeing traveling rates going down instead of up, especially, I like to travel to the north in the wintertime. Those rates usually go up because it's hard to find people. But like when I look around right now, the rates are absolutely awful. I see a lot of times surgical techs making more than a surgical assistant. I understand it's a function of availability versus skill level. I understand that, but I'm just wondering, i- structuring that discussion or that presentation to the right people at the hospital in a way that they can see where it's financially beneficial because, it seems to me like you said, the hospitals rather keep the money than pay somebody. So it seems like the, I think it would be very hard to go into a hospital cold and do that. You need to have an advocate. Usually that's a surgeon because they can best articulate it. There's somebody on staff, they're a proven performer and things like that and you can show them that yes, we do provide a service. We are a force multiplier. We do get these cases done faster, safer, more efficiently, which saves time, money, and saves the patient anesthesia time and everything. And I think with maybe like what we were saying about getting on staff at a hospital, getting credentialed, while it may be in a certain area of the country, a lot of these hospitals are owned by bigger corporations where, maybe in one state, that's not common for them to credential an independent surgical first assistant, but in another state where they own hospitals, that's the norm. So it might be initially hard to push past that, but I think it can be done. And I think it should be done. I'm starting to see that more now with traveling. They're requiring you get credentialed through medical staff, which also adds more of a lead time to starting the position. But that's neither here nor ultimately, I think it's better for our profession that we get credentialed through medical staff.
Yeah, and I've always been through medical staff, so when the there's some facilities now that are actually just trying to like you're a vendor. They're credentialing you as a vendor. I'm like, that's not what I am, because
Mm-hmm.
insurance and the things that they want you to get as a vendor are very different than what you're required to do, as a medical practitioner. And
Mm-hmm.
you're not practicing medicine, but you're still in that, and it's a different tier of people inside the hospital. So it is a harder, that's a longer discussion, I think.
Mhm.
But it is definitely feasible. I think if there's a need, if you can find out if there's a need, then the hospital, then you work backwards into, whether they, you have a doctor or something that you want to be that you want that's there. And, some states, only use nurses. So, you
Mhm.
have to know what they credential to. But, most of us that are in a state where we're actively working, we know that if you're actively working in your state, you can do the same thing as an independent, and, you know, m- a vast majority of the time.
And I can see just from, and I'm just going to throw this in there just because you brought it up when you were talking about that. And, I've said it before and I've said it on this podcast that I currently work as a locums or a traveler, but I cannot tell you how many times almost every hospital that I've gone to as a traveler, they are so grateful for some, and I am not tooting my own horn here, but they're so grateful for somebody that's well trained and knows their job and is good at it, because I hear it time and time and time again, especially at hospitals where they credential surgical assistants on the medical staff, is that we have people show up as travelers that say they can do the job, but then they get here and they are brand new, or they don't, or it takes them forever to close a wound, or they don't come as advertised. And I'm seeing that everywhere. And I'm not casting aspersions on anybody as a traveler that's new to traveling and new as a surgical assistant. But it seems to me there's been a big change that you get people showing up that can't do what they say they can do. Then it's a big liability for everybody involved, in my opinion. Or like, you're short staffed, you need somebody that can show up and do the job right away, turnkey. Now you're going to have to train somebody that has no experience, that you have to train them to close, that doesn't know how to how is that a benefit to anybody? I don't understand. So I think if you're a well-trained, experienced surgical assistant, you're much more likely to succeed in this kind of endeavor.
Mm-hmm.
Well, and that's one of the good things also, that if they are taking in travelers, then you can get in there as a contractor.
Okay.
That's the same exact thing.
Great point.
And they're spending a lot more. Now, what places are willing to pay you is way different than what they're getting paid. They're going to pay you as little as they possibly can, and then keep the rest.
Mhm.
It was not uncommon that OR nurses were getting, or nurses in general were getting $250 to $300 an hour was what the hospital was offering, and then you're offering $100 an hour, and it was, oh my God, $100 an hour, yes, but they got other money. So you have to, if they take travelers, then they'll take this kind of model as well.
Mhm.
Okay.
Oh gosh, I had a good question. No, it
Go
went out of
for
my
it.
head. Oh, no, it went out of my
Oh,
head. It went right out.
hate that.
I'll think of it in a minute. But it was along those lines of. Oh, I was going to ask, what do you think, David? Can you speak to what is driving the low rates and traveling right now?
It's not needed as much, so the hospitals are always constantly, the people who are hiring the travelers, they're not as concerned about some of the positions. The hospitals are going to offer the least amount that they can possibly offer, but
Right.
as the owner of the agency, there's always somebody going, oh no, I need to go and do it. Whereas when there was nobody that was willing to do it, they had to pay what they really were willing to pay. Whereas,
Mhm.
it's supply and demand. The demand is probably still about the same, but the supply is higher now.
Okay, so it is kind of a
Okay.
saturation in the market
They're like,
then.
okay, well, more people are asking, so we're just going to offer less, and somebody's going to take it.
Okay, all
That's
right.
right.
Like when I was doing it, we were competing with 50 other agencies for the same exact position.
Uh-huh.
And then the hospitals got to pick, but the hospitals were offering really good money at the time.
Right.
Whereas now, they have employees. I can't even imagine the thousands and hundreds of thousands of dollars the hospital loses by not doing cases. So, for them to pay a couple dollars extra obviously doesn't lose that much.
Mhm.
So they have the resources. They just, the supply is a lot higher now, and there's always somebody. Like you see all these ads for, from recruiters, quote unquote, who have no idea what, they're not
Mhm.
actual recruiters. They're just people putting out posts.
Mhm.
But they don't know what they're asking for, and so if they can save the company money, maybe it goes back, to get some kind of bonus. I don't know. But surgical assistants, unfortunately, I think most hospitals don't know what it is, so they always offer less. Surgical techs, in my experience, have always gotten more. I'm seeing, radiology techs are
Yeah.
making $4,000 a week still.
Wow.
Yeah.
Yeah, 3 to
So
4, depending on where you're going.
But is that
Mhm.
because the availability of them isn't as great as some of the other professions,
I
or?
guess, and like I said, people just don't understand.
Well,
Like,
that's
it
Well,
fair.
was 50 to 1 scrub techs versus a surgical assistant, or And then the ones that were a surgical assistant, a lot of times they go, you're going to be both. Well, no, it's one or the other, not both. It's two different jobs.
Mm-hmm.
And that I think is, we spent 25 years hiding because we were all making good money
Mhm.
instead of out there
Wow.
going, this is what value we add. And so a lot of people just don't understand the value.
Okay. So
Okay.
would becoming an independent, and we may have hashed this again, I'm just going to ask again for our listener because I do believe this is on their mind. So versus as an alternative, a viable alternative to traveling right now, is a viable alternative becoming an independent contractor and just finding the right hospitals to market yourself to?
I think some of these travel positions, you end up with a non-compete of some sort, so you can't go back to that same hospital. I think you kind of fall into the position of, oh, well, they need help. I think going to search for them is much more difficult. It's always an introduction
Yeah.
that ends up the right way because everybody, the doctor, when he starts on day one, he's already got something in his mind. So, you meet people like, hey, Dr. Jones, you meet a rep. Oh, Dr. Jones was in the OR and his surgical assistant is retiring. And then you're like, oh, okay. And then it just falls in your lap. It
Mm-hmm.
isn't like oh, I'm going to go independent. I think a hybrid type position where you're working for a facility and you talk to the docs that are at your facility. Hey, when you go over to the other one, what do you guys do for surgical assistants? And you
Okay.
kind of your part-time job becomes your full-time job, you know,
Okay.
because it's really hard, I think, in most of the high paying areas because
Uh-huh.
there's some group that's there, and there's always, the doctors after they're starting, they've got something worked out. So you
Okay.
think it's
So it can be
education.
done, but there are lots of caveats,
Mhm.
like little
Yeah, I think
I
now
see.
it's a
is
niche.
harder. You can't just go, okay, I'm going to be independent. I would not start
That
that way. I would get your experience with either groups, kind of
Okay.
living that independent life, see if that's really what you want. Even, because of time schedules and all that, or
Okay.
you work for a hospital and then you work yourself into doing the independent. I would not like people
Just go
going
cold.
to first assist school and
Mhm.
then coming out and going, okay, I'm going to go be an independent. I think that's a
Yeah.
terrible idea. I
Yeah.
Let
don't
me
think,
ask you a
Okay.
question, David.
you're not experienced enough in the profession where you're now having to do that. You don't want to learn that and learn how to run a business at the same time.
Absolutely. Yeah.
Gotcha. Well, let
That's
me ask
not
you a question that goes along with that, just as a hypothetical, and this is more aimed at the people who've been experienced surgical assistants, and this is just a hypothetical. I'm not thinking about doing this, but let's say that the area the area of the country in which I live, I have never traveled in nor worked as a first assistant. Let's say I wanted to move back home and become an independent. Do you suggest maybe starting on staff at a hospital somewhere to learn the lay of the land? I mean, because in the area where I live, I used to work as a surgical tech a long time ago. So I still have friendships with surgeons, still keep in touch with them to this day that I know. So if somebody were to do something like that, let's say they've been traveling for a while or they lived in another part of the country and now they're moving to another part or moving back home or something. And so if I move back to my hometown and I wanted to eventually start and be independent the way we're talking, whether it's hybrid or whatever the billing modality may be, do you suggest that maybe they get on staff either per diem or full time to see the climate and the lay of the land before it, and to see, obviously that would be smart to see if the need is there and they can sustain it because, of some of the things you've said in the past about how many cases you need to do, you know.
The short answer the easiest way would be yes, to get a job and then work yourself into the area. But if you already have been there and you already have contacts, then you float the idea of, hey, I got Dr. Jones, Dr. Smith, and, that are working 4 days a week. And they said that I can go help them. So the last day is when you do the hybrid position and you start off independent with them at the beginning
Mm,
because you're going from a position of, you already have the contacts, you get all your credentialing and everything before you ever show up. So on day one, you're starting. The challenge
Okay.
is, it takes time to make money. So you want to have, 90 days, 180 days of bills covered, because it could take time. But that's also
Yeah.
why you go, okay, well, I'm going to work with these guys Monday to Thursday. I'm going to work Friday, Saturday, Sunday, on call and for the facility. So if you have contacts, you can go into it. But if you don't, then you definitely, I would not try to be independent and just move somewhere. Go, oh yeah, I'm just gonna be independent. I wouldn't move there until I had a job. I would get
Gotcha.
on with a hospital, surgery center, somewhere where you're in the community of people that are gonna, you know, see your worth and your value, and then they're gonna suggest you to somebody, or they're gonna tell you about this doctor that just lost their first assist.
Right. And
Gotcha.
that's where
Thank you.
networking, it's just networking and forming relationships with people and word of mouth really
Y-
help out, I
Yes.
would think.
Yeah, it's
Thank
not an
you.
advertised job usually, and when they
Right.
advertise,
Right.
they advertise the job, but it's usually not really that. It's a scrub tech that does some
Correct.
first testing.
That's
Right. Well,
right.
I'll give you a prime example. I took some time off earlier this year, about 3 months, because I had a lot of stuff I needed to do, and I figured, "Oh, well, let me talk to one of the surgeons I used to work with and see if they need a per diem first assistant." And they were like, "Yes, come to the hospital." Set up a meeting with the OR director. This surgeon set it up. Surgeon was in the meeting, and I told the director exactly what I was thinking, and she's like, "Well, no, our first assistants don't do that." And I'm like, "Well, what do you mean? Like, what do they do?" And she's like, "Well, they just hold retractors, basically." And I'm like, "Okay. All of your orthopedic surgeons have PAs?" "Well, some of them don't." I'm like, "Well, what do they do in that instance?" "Well, they bring their own first assistant." I'm like, "Okay, that's exactly what I'm talking about." She goes,
Yeah.
"Yeah, but they don't help out on weekends or nights." So I was like, "Oh, okay. So then you're saying there's an opportunity that these surgeons would need a trained first assistant on nights and weekends to help them." And this person was like, "Well, yeah, if you wanna do that kinda thing, sure." And I'm like,
Yeah.
"What do you think I'm talking about?" But
Yeah.
there's
They
What
don't
do, what,
know.
do-
seriously.
what do you think the
Right,
meeting is for? Yeah.
They
right,
don't know.
right. And they
Yeah.
don't even people who work for them, they don't understand the full capabilities
They don't.
of people that they employ, and it's a multifaceted problem that we could probably do a series of
Mhm.
podcasts on, but,
Right.
there's a lot of people just want more money, so, they just wanna be a tech that can close skin, or there's a multitude of reasons, and I'm not casting aspersions on anybody for any reason they wanna do something, but I
Yeah.
don't think that, but yeah, in my experience, that they sometimes the directors don't even know
You have to go back
that
to
that's even
basics and start
possible.
with, yeah, education about about our scope, who we are, what we do, how we're trained,
Exactly,
what the options
exactly.
are, what the possibilities are and scenarios are.
But I think if you have an in with a surgeon, I think that's a good idea. I think,
Mhm.
Kelly, unless there's something else you wanna add, I'd like to move into the what we were talking about with David's
I
announcement and the post he
Yeah.
had made on Facebook.
Mhm.
David, you feel comfortable moving into that and talking about that?
Sure.
Wonderful. Thank you so very much.
So one of the things that we've all noticed, and so I would say post the NSA, the No Surprise Act, we've seen we're getting paid more often, but we're getting paid less each time we're getting paid. People are used to, you would do a total knee and you'd get a really big check, but then, you would get one check or two checks out of the whole month. And you were like, okay, well, as long as that maintains, I'm good. And then over the years, you're losing, 20%, 15%. And now here we're 5 years in, and now you've lost 70% of what you used to make. And
Mm.
you're like, okay, well, how do I do more work? Which, I would argue that most people could do more work, or do I do something different? And, what I've noticed is, in our hands, we have seen probably 5 to 15% year over year reduction from the insurance company, at least on that initial payments. So what a lot of people did is they said, okay, well, now I'm going to go bill the patient. Because again, nobody was billing patients at the beginning. And it was like, well, patients only pay 12% of the time. They don't even care if you send them collections.
Mhm.
And then they have all these new rules that you can't send recollections for healthcare bills because healthcare people are evil and we cheat everybody. And, we don't provide any service and, we're getting paid just fine.
And we
Or,
we make a ton of money. Yeah.
yeah, we make a ton of money. We're making millions. So
Not. Yeah.
the No Surprise Act added um, value for the insurance company to underpay drastically because everyone was going by a database. And that database said, we're going to take your average of the last 90 days. And then this is your argument of this is how much you're supposed to make. Because if you do globally, this is how much the insurance companies are ultimately paying. So that was a pretty good argument. But then following No Surprise Act, everything, they just kept low paying. And we're like, man, what are they doing? And then that was it. They were modifying the database because the data was going low.
Mm.
So what ended up happening, the government said, okay, well, we're going to do this arbitration thing. And it has been, 4 years, and it's almost 5 years now. And it has been nothing short of a mess. It stopped and started, and, we still have cases back from 2023 that they're looking at. And according to the writing, it was supposed to be done in 60 days. Now, can the process be done quicker? Maybe, but it depends on your state, depends on your arbiter, it depends on the insurance company. There's a ton of back and forth. So with that being said, I had a company that contacted me in the summer, and they were kind of random through LinkedIn. It was really weird. It was like, or hey, do you have any surgical assistants that you do billing for that are seeing low payments? I'm like, well, yeah, because everybody is right now. And they said, well, we're offering to buy cases, and we've all seen these deals, and they were offering basically, like you were a contractor, at a hospital, or you're working for a surgical assist company, basically. And so you didn't really have your independence. You were going where they wanted you to go, and they were buying the case. It was what did we call it? We called it like a almost per diem, but like a co-op. They would give you the docs, and then they would pay you for the case.
Mm.
Well, this is a group out of New Jersey that started out as a neuro practice. So neurologists couldn't find surgical people, and New Jersey only allows PAs or RNFAs.
Okay.
So they were hiring people to cover cases. And then they were like, what do you mean, you're not going to pay this amount? And, this is just crazy. So they started basically doing the arbitration and doing the arguments and doing they were hiring all these people as 1099s and billing all of the different ones underneath their tax ID. And what they found is that the more people they had underneath their tax ID, the more the hospital, or they had the negotiating power of a hospital.
Mm.
So the insurance company was like, well, you're just you have 5 people. We don't care about you. But when you have 150 people, now you have real numbers. You're like, I have 150 providers. If I stop seeing your patients, they've just lost out in care over here. So what they found is that they were able to argue better for reimbursement from the insurance companies. They had some lawsuits that they won. They had some arbitrations, but arbitrations are never really the thing, because you win some, you lose some. It costs anywhere from $600 to $800 now to arbitrate, and especially with us as independents, you never really have, when you arbitrate as a batch, you have to have the same exact type of case, the same codes, everything has to match. And whereas us, we're always doing different things, and we don't have them, all clumped together in one day, because the time frame is extremely important only on our side. Once you give it to them, they don't care. But on our side, we have to meet very strict time constraints. The government didn't say you couldn't appeal, just made it so difficult to follow their rules that you really couldn't. So then we get back to, well, how do you get paid? So, what they started doing is they started buying cases like other companies were doing, but then putting those cases and billing those cases out underneath their tax ID. And what they're able to offer is they're looking at average amounts. So say my average is $250. It's very easy to look that up in the reports. And you can go, okay, well, it is average, but I don't need you to just pay me what I'm already making. But what they're doing is they're taking above average payments wherever you are or whatever you're doing. They obviously their background is they were in the spine world as one of them was a striker high up as a VP. They were both spine reps at one point. They very well connected in the business world, so they have good financial backing. But what they're doing is they're offering anywhere from $350 to $1,500 for specific cases. So if it's a commercial insurance, so we all know you can't argue with the government. The government pay, and that's all they got. That's all they're going to give you. They're going to use the justification of CMS, and that's it. Well, this company, what they're doing is they're contracting with the surgical assistants, PAs, RNFAs, regular surgical assistant, licensed, non-licensed. And they're taking every payable case with a payable insurance, and they are offering a set rate. So it's not the code, like say it's all general cases or all ortho cases, and then all spine cases. They all have different tiers. They make the math easy. What a lot of these companies did is, and there's other companies out there now saying, okay, well, we're going to do your arbitration for you. And if, you're going to make $6,000 a case. Well, that's not true. We've done arbitration. We won every one of them that we did. We have great arguments. The problem is that the numbers that you can get barely outweigh the cost of the cost rate. So what they're doing is they're paying every 2 weeks. And if the insurance pays, it's on them. If the insurance doesn't pay, it's on them. If they do arbitration and it loses, they eat the cost. If they win, they do get to reap the benefits. But it's very specific what you can do arbitration for. It's not an all call. It never has been. It's getting more strict as it was in the past. And what they're doing is they're saying, we're going to bet that we can negotiate now because we have 200 providers underneath our one tax ID. We have 300 providers. We have 500 providers. We have 4,000 cases a month that we're sending to Blue Cross.
So strength in numbers is the concept here?
Yeah, it's all about the numbers. And we've always said that in our world is, look, if we could get everyone to agree on something and say, no, we're not going to do it different, we would win. That because there's always somebody who says, oh, well, we're gonna go ahead and pay. We'll take that lesser pay. And this is the same thing that hurt the doctors over the last 40 years. They were in 95% of what they billed. They're billing the same exact amount they billed 30 years ago.
Right.
Now they're getting 19%. So they're not getting the money because they can't agree and fight back against the insurance companies. So what these guys are doing is they're taking the upfront cost and risk and paying every 2 weeks. So you don't have to worry about, do I bill the patient? You don't have to worry about, do I have to worry about, the hospital, sending me my money? Because no one wants to pay you. I don't have to worry about the insurance. Once you give it over to them and you send them the same thing you would send if you're independent anywhere else, you send them the codes, the op report, and the face sheet, everything else is done. Unless you don't send them the correct information, or if the insurance and I don't know how people ever have surgery and have bad insurance the very next day. But, if you can't get a copy of the insurance, then obviously that's a take back. But otherwise, they don't take anything back. All the risk is on them and all the benefit is on the person they're buying it from. Now, look, can you make the argument that, well, if I just wait it out, well, we've been saying that for 20 years.
Mhm.
Just wait it out. This next one's going to be the one. Yeah.
Yeah.
The way that they do it is there's no minimum, there's no maximum. The only criteria is it's got to be payable and it's got to be commercial. So if you say, okay, I'm going to do a hybrid, I'm going to go over here, I'm going to do these 5 cases that I know are that this insurance is really, really good, I think I'm going to take the risk. And then on these HMOs, they don't have out-of-network benefits. So let's send that over and let them take the risk. They somehow have the ability to even get passed through that no benefit thing. So,
So is this a billing company then, or do you work for that company as a surgical assistant? How does that
work for
play
that
out?
company as a 1099. They are not a billing company. They are a first assist company.
Group. Yeah.
Okay, gotcha.
And the other thing that they do is they actually do pseudo staffing, more like a co-op, where they have doctors like I said, they're very connected in the rep world. So they have doctors that call them and go, hey, do you have anybody who can help me in this spine case? Do you have anybody in this area? I don't have a first assist.
Oh, okay.
Or they sell the models like, hey, doc, we can provide you with somebody. We have 20 surgical assistants that do our program in this area. We can find you somebody to help you. And so again, there's still no requirement that says you have to send all the cases, and even the things, workers' comp, government policies, Obamacare sometimes actually does pay, Medicare replacements, all that stuff, you still send the same way you were doing it before. You have a contract with a hospital to pay you for those. You can still send all those to the hospital. You just don't send them the commercial payable stuff, which is what we always have said is if I make this dollar amount per case, it's dummy math. It's really easy to figure out. Oh, wow, I did 10 cases today and 5 of them were spine, or 5 of them were ortho. We'll take that number. And these guys, I negotiated for $500 a case. Well, now I know I made $2,500 in that day, in one day. So, these guys are doing it direct deposit. You get your money every 2 weeks once the case is accepted. So you don't have to wait the 21 days to send it to an insurance company. You don't have to, as soon as you can get it, you can get paid. And they've been very upfront about the way that they do things. And look, there is a chance that you could fight the good fight and win some if you wanted to do it on your own. Mm-hmm. But I will tell you that, billing companies, we don't have negotiating power. It's the number of people underneath the one tax ID that has power.
Gotcha. So then you'd still have to wait for to file an appeal and all of that. So now you're looking at 120 days.
Oh God.
So the way that the claim, the life cycle of a claim. So like I said, you could wait, but you're going to hold it for 30 days to 60 days to help remove the chance of you getting caught by a deductible, out of network or in network, depending on how the insurance company wants to process it. Then the insurance company has 30 working days, which is about 45 days, to respond. So here now we're at 90. And then on the appeal side, if it's a No Surprise Act policy, you have to, one, catch that it is, and then send the appeal, and then they have another 30 working days, so another 45 days. And then the arbitration process starts. So there's back and forth. There's the notification, which you have like a 4-day window. So you have to notify them that you want to use the arbitration. You have to tell the state you're going to use arbitration. Then you both have to agree on the guy and all that back and forth. And if you don't agree, then the state picks. And then the real time starts of, okay, well, this is the information you have to send to them. It's a fairly easy template once you are there, but you're selling why you have to make more money without asking for more money, because that's the only thing you can't argue about. I'm like, well, then what are we arguing for?
Right.
I'm already there. I did the work. So, they've made it So it's very tedious. And there are some companies that are pretty good at it, but you're going to wait 6 to 18 months for money, and you may or may not win. And then whatever they do pay, you're gonna pay. If you win, you get the money that you would have spent for arbitration, $600. The insurance company has to pay that. The problem is now the insurance company has up to 45 more days to pay you that one case. And it's only one case. It doesn't carry any weight forward. Like what they said is, now I can't argue for that case for the next 90 days. That's the cooling period. But the insurance company doesn't have to pay you that agreed rate for the next 90 days. They only have to pay it on the one case.
Oh, wow.
So how does that, it's like you have to argue every single case.
Right.
So where's the math in that? If you're going to spend $600 to $800, now you have to make $3,000 on everyone, $6,000, which that's just not going to happen. They don't, even in the best hands, they're saying, the hospitals are getting 75% is what they're saying. There was a big survey from, hospital association. They're winning 75% of the time, which just tells you that the insurance company shouldn't have this ability at all.
Right.
So again, it goes back to lawsuits. You got to have lawyers. Lawyers take 30%. That's the only thing that the insurance company really looks at. And the fact that they're going to have, 90 claims at once that they're going to have to sell. So now they're going to, be a little bit better. So it's a volume for them to make money. It's a volume game for them to pay it out. And then the volume helps them with the argument.
Right. There's no upside for the insurance company to pay you on time anyways without arguing.
No.
They're banking on people just getting frustrated and not following through with the process or not having a good biller. So is this company that you're talking about out of New Jersey, is this more suited for working independent surgical first assistants? But I know you said there's the opportunity to get possibly cases from them if there's a surgeon in your area that needs somebody and contacts them.
There's a little bit of everything. If you want to do moonlighting, you do that one day a week. You're like, okay, well, I'm going to take my chances and I'm going to get, I'm going to go help them with knee scopes and rotator cuffs and total knees on that day. They have payable insurance. You can turn them into here, and then you just bill the rest. It's a supplement income for some, and it's a huge income for others. It goes back to, like if you're doing, we'll take, 10 cases a week, and 30% of those only 30% are commercial. But now you have a guaranteed amount that you're going to make for that 30%.
Right.
The other ones are still, up in the air, but they had it to where, they weren't even, the people that they were doing the commercial cases weren't even billing out anything else, or they were giving those out to other people. So what they're doing is they're giving us those cases that they can't be billed out, like the Medicare and the workers' comp and, Medicare replacements, because you can still make something. Like I said, don't do it for free just because you're making good money on the other side. It gets us right back to where we were 20 years ago. You still want some argument. And then these are the type of people that, you put those kind of numbers together in one lawsuit. That's the kind of stuff that changes legislation. So to me, I see that as an advantage that maybe I can bring to them later and go, hey, we've given you all these clients to do this stuff. Where can you help us in this legislative effort? Who do you guys know? Because they know a lot of. And then, hey, are you guys willing to donate some to this? Because obviously, if you guys couldn't make money, you wouldn't be offering it. So there's some money in it, but it's are they being greedy? I don't think so. I think they're taking the opportunity to get people. They're like, even groups. I want to expand my group, but I can't do it because I don't have a set income. Right. Well, now you negotiate it, and what I was putting out is it's basically they're doing $350 for C-sections. They're doing $450 for general. They're doing $550 for ortho, and they're doing $1,050 for spine and neuro. So if you just do that, that's the base rate. It's you can always negotiate higher because why not?
Right.
But when you have a base rate of this is the minimum I'm going to make, now you can look at it and go, well, let me do that math. I do 40 cases a week with these people, and I make $60,000 a year. If I did, you can just do the math.
Yeah.
Right.
And
And
they
sounds
don't
like
have a long-term contract. It's either you send them cases or you don't. They have a business agreement, which you have to have, and a HIPAA letter, which you have to have. And I believe they have a non-compete where you can't take their model and start it yourself.
Right.
so it sounds
Right.
like they assume a lot of the risk then of
They
billing
assume-
independently.
100% of the risk.
Are you at a point with this where you can mention their name and we can direct people to that, or are you still like things being worked out?
Well, so it's All-Star Surgical Assisting. They're out of New Jersey, and they are becoming a very hot topic. There's, how the surgical assist world is. Once one person's
Yeah.
in, they're like, oh, I found this great deal, and they're offering it to everybody. We all
Would you s-
talk, this is what we want to do for the next guy.
I have a separate question too, but I want to ask you, David, knowing what you know and what you've learned about them, would you say that you endorse the
I do.
model and endorse
I
their?
do.
Yeah.
We actually have a good handful of clients that are doing it and already getting paid by them.
Now,
So it's just a matter of, do you need the money now? Do you need them? You want to wait, or do you
anyway,
just
yeah.
do kind of a hybrid thing where you're doing a little bit, because it doesn't prevent you from billing out your own cases. Worst case
Right.
scenario, if for some reason it's short lived, you go back to billing the same way you
Right.
were before.
This sounds like the perfect platform for somebody that wants to transition from hospital-based to independent, where you can mitigate some of the risk.
Yeah.
Sounds
Yeah,
like
'cause
to
you
me
never know.
anyway. Right.
Yeah. Yeah. This
So
is
did it? Yeah.
definitely.
When you're ready for my question, I have a question.
Go ahead.
So when you're ready. So when I want to make sure I'm understanding this, so they are we're the commodity, and they do all the back work.
Yep.
So they're essentially supplying us. Would you say that this is similar to the model that when I hear CRNAs are locumed out, do you have any knowledge of that? Is it like, I've worked with a lot of CRNAs because our hospital corporation that I work with recently bought out our anesthesia group. And so a lot of the CRNAs have left. Several of them have, and they go locum. So when CRNAs are locum, and is it kind of the same thing?
It
Is
is
it
in
a
a way
similar?
because they work with the company, but they're not employed by the company. It's almost like a staffing agency,
Uh-huh.
but a staffing agency that bills the insurance companies instead of a staffing agency that gets paid by the hospital.
Hospital. Okay.
Gotcha.
All right. That's all right. That
So
makes
depending
sense.
on the region, they go from PAs down. They even do docs. They have some doctors that still first assist.
Mm-hmm.
So, they look at it as, and the way I see it is more of a staffing agency in the way that they don't get their money from someone else. They have to still bill the insurance company.
Right. Does the contracted employee have any dealing with the facility that they're going to be working in other than getting credentialed at that facility?
Well, that's if you're looking for them to place you somewhere, then
Okay.
you would have to you would still have to do your own credentialing. And the only thing that they make you have is your own liability insurance.
Liability. Yeah.
But that's standard anyway. You can't
Right. Sure.
do it without it. And I think that started because the model that they were doing at the beginning was all PAs, and their liability insurance is a lot more expensive than ours.
Mm-hmm.
Okay.
Okay.
So they were like, well, you have to cover that, and then because we're going to pay you really well, you can cover it yourself.
Okay.
Gotcha.
All right.
And I know that there's a fee associated with credentialing at hospitals as well. That's
Yeah,
not
some of them now are
nominal.
doing, what is it, like $250, because a lot of them have outsourced the credentialing to somebody else, and they don't want to pay it.
Yes,
So
that's true.
they charge
Right.
you and pass the cost.
What I've seen
Right.
typically is 250 to 350.
Yeah, we had one that was 400 for a memorial facility out here in Houston area when I used to get credentialed for the medical device company. They would make us.
Mhm.
I'm like, really? It's just a money grab now. The
Mhm.
stuff hasn't changed. You don't need
Yeah.
$400 to figure out that my insurance state is different.
Right.
Oh, that's true. But I think there's a tremendous upside for us as surgical assistants to be credentialed through medical staffing for the legitimacy, the professionalism, not only that affords us certain privileges at the hospital to be on medical staff, whether it's in the cafeteria or one of the other ones is definitely in the medical library, because institutions have institutional subscriptions to all the journals that you now have access to for being on medical staff. So
Mm-hmm.
that can reduce your costs at home. So you don't have to maintain Journal of Trauma, Journal of Bone and Joint, all that, which are not insignificant. I've looked at those things. Some of them are $650 a year just for the
Mhm.
journal.
Yeah.
Yeah.
So yeah,
And yeah, anything you can get from a hospital, because hospitals don't really want to give you anything anymore.
that's true.
But like here, it's all outsourced. Like you call a hospital for credentialing, they send you to this outsourced place that
Right.
it's literally just collecting documents. They don't even know what you do.
Yes. And they don't even do it correctly half the time.
Yeah, they
That's
don't.
been my experience anyways. I just went through
Yeah,
that
well,
process
especially
and it
with
was a
traveling.
nightmare.
That one, it was
Gosh.
harder to get a traveler credentialed at a hospital than it was to get, to be on medical staff. The
Yeah.
amount of stuff
Yeah.
that they wanted to know, they wanted
Mhm.
high school and I'm like,
Oh my gosh, I don't
they literally wanted your high school transcripts. And I'm like, wait,
That's
come on.
What does that have to do
insane.
with anything? Yeah.
Yeah. It's things that didn't mean anything for what we were trying to do. I'm like,
Mhm.
all you need is what I could do and where is my insurance?
Mhm.
Everything
Now,
else covered.
my caveat, while I think it's great and I hope more hospitals credential us through medical staff, there needs to be a truncated process for that, because I had a recruiter of mine call me just to ask some questions about credentialing because they know I've been on staff at several hospitals. They asked me a bunch of questions because there's a hospital in their system that they contract with that they provide travelers to that tell them, listen, your travel first assistants need to be credentialed through medical staff, and there's a 100 up to 120 day window that it may take. I'm like,
Yeah.
what traveler is going to wait 120 days in between assignments
Yeah.
for that to
Exactly.
happen?
You end up missing all of them because they
Right.
put them out there and they have like 3 weeks to get them filled.
Yet
Mhm.
most people, I know for myself, we start looking for 4 weeks out at the end of our contract. But then you add that, like, I'll just give you my personal experience recently with a travel assignment I took. It took 6 weeks for me to get credentialed. Now, I just happened to be off at the time. So it really, I had that luxury of time. Not everybody does. And I spoke to the people at this hospital. They're like, you don't know, it's so hard to find a surgical assistant. And I'm like, yeah, I'll tell you why. And then
Yeah.
the
If you're doing
process was
this.
riddled with issues that were, it was all on their end. They were sending the wrong information to the, for the references that they wanted. And I'm like, you can't ask for references anymore. They only give you dates of employment. It was just a ton of issues that they don't understand. And I'm like, well, you want to fix your problem. That's where you start.
Yeah.
You get a
Yeah.
streamlined procedure for travelers.
Well, and we had one that we set up. It was actually in West Virginia, and it was a scrub tech, and they wanted the drug test within 72 hours of the start date. I'm like, well, that's Friday to Monday. I'm like, where am I going to get the results to you by Monday
Right.
Yeah.
when I do it on a Friday? I'm like, so it was always a challenge. That I think the money was good in that from the business side, but the headache and it took what was it, 13-week assignments.
Yeah.
I was in the middle of my second one before the renewal, before I even got my first check for the first one.
Oh, wow.
So I was
Mm.
floating like $300,000
Jeez.
before they ever paid me. Now I think at the end, I don't even remember if I made any money, because at the end I'm like, well, if you have to, it's the same scenario as what, if you got to wait that long for it, it really doesn't mean as much.
Right.
Right.
And all the hospital contracts they were supposed to pay in 30 days. So I'm like, oh, you put a certain amount away just to cover all of that, and they weren't paying that.
Mhm.
Wow.
And then if you pull your person, you're in breach of contract. and they just won't pay you at all.
Mhm.
So, this is even something that you can look at, in your off time, when if
Sure.
you're a traveler,
Wanna
because,
moonlight? Yes.
moonlighting works, the hybrid works. And again, it's like being in network because you have a set amount.
Right.
You're in network with everybody for the same exact amount.
And it's not just in New Jersey. You don't have to go to New
No,
Jersey.
it's everywhere besides New York and California.
Okay,
Right.
so the only 2
So
exceptions are
they
so
work
they
with
even do it in Jersey then.
they
Yeah.
work with assistants all in all the states that
Yeah.
are
So
that are
so
applicable.
the way that they're set up as a medical practice because there's
Okay.
a surgeon that owns the business, and he uses his medical license to get a practice in every state.
Oh,
Okay.
gee. Okay.
So
All
that
right.
also is a different, I guess, a different way to argue it for them because it's a medical practice and not an independent surgical assistant or a surgical assistant group. When they argue it
Mhm.
as practice, somehow the
Okay.
numbers are better.
What about are they
Okay.
able to do it with the federal government, i.e. VAs, or no?
No,
Okay.
no government policies, but
Okay.
you can still do all those cases. Like I
Right.
said, you just do whatever you were doing before.
Yeah.
Gotcha.
Well, David,
That's
that's
fantastic.
exciting. Great information. And
Yes,
again,
thank you
we are
so very
not
much.
yeah, as a podcast, I mean, our listener was able to hear David's professional endorsement of this
Yes.
business model and of this company, but John and I have no dealings with them at all. This has just been purely informational, but it is All Star Surgical Assisting. They are headquartered, I guess, in New Jersey, and we can post a link. Or you can just Google them to find out more information. But we're
Yep.
tickled to death again that we were able to bring this
Thank you.
information to our listeners, David. And prior
That's
to
right.
that, just get so much insight from you.
That's right. You heard it
Invaluable.
here first.
You heard it here
That's
first on the
That's
Kelly
Well, like I
right.
said,
and
I like
John
doing these.
too.
I think it. Let's send me some dates that you guys want to do for the next one and some
Will do.
topics. We'll try to. I'm all for the education. We're not strong if we get not all on the same page.
That's
Really,
right.
Exactly.
I
And I'm
believe that, and I
And I'm
think
also
if
glad that
you
you
do
brought
it,
up that you mentioned, and I was already thinking that this model of the strength in numbers thing was gonna be good for legislation. So that's encouraging as well for the future of our
Yeah.
profession that something like this can actually benefit us as far as, uh, as far as legislation wise and getting,
Mhm.
validation in that respect, and for states to move into requiring us to be licensed and us getting recognition for that.
and
Um,
most people only care as independents. Like when people are employed, like, well, I don't care if
Right.
my hospital gets paid. I don't care if my
right.
doctor gets.
Yep.
So this kind of thing
Very
keeps people
short-sighted.
independent, even though because we've lost a huge number of good people
Mhm.
to the fact that, well, I lost my doctor and, the reimbursement's so low on these other ones. Now I've got to go work for a group or I'm going to go work for a
Right.
hospital. Or,
Mhm.
so this helps us keep the independent profession, I think, a little bit more active.
Uh-huh.
They are planning to go to the joint conference in April
I
or
saw
March.
that.
So we're
Exciting.
gonna try to get them a table whenever that opens and we find out, all the details about it. But they already have it on their calendar. So
Right. Yeah. So it's just such good information and something for people to look in. And I was going to tell you too, regarding future episodes that we do, if you can even, jot down as you see trends happening, because you see the trends and and that's some of the
Mhm.
things you talk to us about, the trends that are happening in the area of billing and surgical assisting and kind of what's going on that, we're out here working, I work for a facility we're not gonna know about. So if
Mhm.
you have a mind to just jot down some ideas there that we can, discuss on a future episode, but I think things change enough and evolve enough in this profession in general that there's always something to talk about, something new coming up.
yeah,
But
and everybody's, it's like healthcare. Everybody's, they try to reinvent the wheel sometimes when you learn something new and you're like, okay, well, let's go back to this and see if it works in this way too. like unicompartmental knees have been done, every 10, 15 years. And
Uh-huh.
they haven't really, they made the incisions smaller, but they really haven't improved the fact that they don't last that long.
They
So,
have to come back. You come
you look
back
at
and doing that
everything
total.
cost versus benefit, and
Uh-huh.
medicine, you look at the same thing in billing. There's always a cost versus benefit, and
Right.
people, unfortunately, they get short sighted on, you know, oh, I can make this big money, but you know, again, we go back to the way billers talk to people. And we talked
Mhm.
about it even before we started the episode. Is they tell them one thing, but then they're already 6 months in, and when they realize, well, they didn't. That wasn't completely accurate, because I can show you 100 cases a month that the payment was 100% of what we billed the insurance company, but
Uh-huh.
I can also show you 1,000 cases a month where it wasn't.
Uh-huh.
So you've got to, everyone's going to show you the best leg forward, but the reality is what do you need in your current situation, and
Mhm.
always adapt it to that. And if you need money now, then you kind of a hybrid thing. If you are like, hey, I'm in this for the long haul, and I'm good with money, and I don't need to do that. Or if you're like, hey, I can't run a business, I'm just going to
Right.
go work for the hospital.
Right.
Or, hey, I want to dabble into this. I'm not really running a business, but I do have the chance to do independent stuff. Now you can do something like this, not even run a business, because all
Right.
you're really doing is turning over face sheets to somebody else to try to build them.
Yeah, it's really
Yep.
I think it's a good thing. I think
Yeah.
it's great to have
Yeah.
that option. Have you known anybody? Did you tell us if you've known anybody that has transitioned into this specific company?
I have 7 of my clients, or
I
8 of
think you did say that.
you.
Okay. Yeah.
And we always look at things as, instead of going to everyone and going, hey, all of you guys try this,
Right.
put it out there. It's not a pressure thing. And, even our clients, we have over 350 clients, and we haven't introduced it to everybody yet. You
Right.
know, some of it is, some people are happy doing what they want to do. And if you
Yeah.
try to change what they're doing, they're like, well, why are you telling me this? What do I don't know?
Yeah.
You know,
Right.
Yeah.
it's always an option. And it's just a different thing for different people and what you can
That's
tolerate.
right.
Like I look at like places like Mississippi or North Florida.
Yeah.
Let's go to Florida. North Florida has a couple places that seem like they pay really good.
Okay.
And then there's some that just have the policies must be bad, because they're commercial insurance, but they don't pay anything.
Mm.
Or if you get down to, South Florida, like Boca or Miami, there's a
Mhm.
lot more money down there, and the policies are better. So in the same state, you've got a bunch of different things going
Wide
on.
variety. Oh, yeah.
Like you said, your hospital doesn't even credential with people, right?
Right. I mean, we're in a big retirement area. We're in West Central Florida. It's a lot of retirees and
But
Medicare.
see, there's always those few that have real insurance. You're like, okay, well, maybe
yeah.
I can, you know, get an extra $2,000 a month. Because,
Mhm.
to us, if, most surgical assistants are, anywhere from 75 to $120,000 a year.
Mhm.
If you can
Yeah.
add another $20,000 a year, or $5,000 a year, you know, why not?
Why
Like I
not?
said,
That's
I don't
right.
know how long this new model will be available, because I looked at it at the beginning.
Right.
I'm like, I don't know, how can you afford to pay that much for
You're
that
skep
long
Yeah.
without knowing you're going to win?
It's behind.
Right.
You know, so, and the insurance companies always figure something out,
Yep.
Yeah.
and they're like, yeah, we figure it's 12 to 18 months, and then we'll have to pivot and do something different with the insurance,
Mhm. Mhm.
because they'll learn how to argue against whatever you win, and which has been the same thing in the billing world. We changed the appeals based on the way that they're denying them. The No
Okay.
Surprise Act took a lot of that out of our hands, where we couldn't, the normal appeal, they just like, oh, there's No Surprise Act, you just can't, we're going to pay you in network rates, and that's the best you're getting.
Right.
Or, and
I have a
then
question.
again, it adds the the pressure of what I used to make versus what I'm making now.
Right.
David, I got a question for you, and if you don't want to answer this, I can edit it out. But do you see them as a direct competitor to you, or no?
No, they're backfilling us with cases that are the government and non-commercial, and they're all paying about the same amount to us and to the things now. And we're actually working a deal with them, on the backside. So there's things that we're
Good.
doing to help benefit the company.
It's kind of synergistic.
Yeah.
Yeah.
That's what it should be. I mean,
And that was the other thing is, well, why would I give you all these cases? What am I getting?
Right.
They've already given us 12 new clients that are billing stuff that we weren't billing,
Great.
Okay.
and have
Yeah.
them as a client.
That's
And
cool.
they had 160 clients before we even met. So that's potentially clients that can come to us and bill the non-commercial cases, or even the cases that they want to bill but don't want to send through the program.
Right.
Sounds great. Sounds like we should wrap this up because this is
Yeah.
it's already an hour and a half. And,
Yeah.
And
Michael's
well,
gonna
look, we
complain that it was a
we
long
used to do
podcast.
seminars on this all day. So
Yeah.
Oh, I would love that, but we'll
Listen.
definitely have you back.
Listen,
But-
we're here for the listener, and I still know, even despite the link, that people are going to have listened to this and gotten so much information. We just really appreciate your time, David.
again,
as
let me
usual.
know when you guys want to do another one, and we'll try to work some stuff into it.
We'll do.
Well, we appreciate everybody
thank you so
listening,
much.
and and we're going into the holiday season. We just want to wish everybody a safe Halloween, and Thanksgiving's coming up, but be safe out there,
Yes.
everyone. And we appreciate you listening, and we'll see you next time. Anything else, John, before we sign off today?
No, I'll end
Right.
it with a joke. What's the difference between a carpenter and an orthopedic surgeon?
Not sure.
A carpenter knows more than one antibiotic.
That's a good one.
All right. Yes, you guys take care. Don't forget to like, comment, and subscribe, and have a wonderful holiday. We'll see you again soon, and we'll be back with David again for another installment. So thank you so
Yep.
much, David.
You're
Yep.
welcome.
Thank you for joining us today. We invite you to like, comment, and subscribe to our podcast. Feel free to look us up on Facebook at The Surgical Assistant Podcast. If you like, you can also email us at thesurgicalassistantpodcast@gmail.com. We look forward to seeing you on the next episode. Content of this podcast is created for surgical assistants and is educational only. It is not intended to diagnose, treat, or offer medical advice on surgical conditions. No patient-specific information is shared, and all HIPAA guidelines will be adhered to.